Happy Friday, Baylor College of Medicine and friends of Baylor. Well, apparently Lily didn't have enough pull to help the Texans. She helped the University of Michigan, but Texas lost. Frankly, I blame it on Lily, but don't let her know. So, some stuff in the news. Lots of respiratory infections. So, Hopkins brought back their mandatory masks in all of their hospitals throughout Maryland. 39 hospital systems are now having mask mandates. The good news is things are beginning to kind of wane a little bit. And there's been some discussion about the symptomatology of the new JN1 variant. Mostly has the same symptoms, sore throat, fatigue, headache, cough. A little bit more GI issues have been related and less of the taste and smell stuff. So that's the new variant. That's what people are saying. The other thing is, just in general, things are improving. Hospitalizations are down. Healthcare visits for influenza-like illnesses are down. The SARS wastewater data are down. I'll show you that in a second. And flu and RSV are finally beginning to decline. The CDC estimates that 80 to 90% of the recent cases are due to the JN1 variant. And in one of the more depressing moments, one of my friends asked me, should I really get a vaccine booster? Anyway, yes, the reason you should get the booster is a lot more closely related to the JN1 variant, which is the circulating variant. The previous vaccinations are not protective, and there's a 50 to 60% benefit from serious illness, so you should get your booster. So the only other thing that I want to show you is that if you look at the U.S. data, it's all pretty good. This is COVID, influenza, and RSV. They're all on the downslope. If you look at respiratory virus from laboratory emergency department surveillance, SARS-CoV-2 and influenza are coming down. If you look at a lagging indicator, the hospitalizations also beginning to fall. And then for the first time, we're really seeing a drop in the wastewater numbers. So it's down to, it's been running at about 50% of the sites reporting 100 to 200% increase. And this week, only 32% of the sites are reporting increases. And remarkably, if you look at just how JN1 has taken over, JN1 is now the dominant strain. 85 to 90% of the strains are JN1, which, getting back to the issue of vaccination, the previous vaccinations do not really protect against JN1, whereas the XBB 1.5 booster does. So get your vaccine. Oh, God. So let's turn to flu. Influenza finally coming down. And if you look at this flu season versus others, this was sort of a big season in 2017, 2018, before the pandemic, when we were all wearing masks, in case you wonder if masks work, and social distancing. Flu almost disappeared completely. We almost had no cases. And then here we are, sort of a standard season in this year for influenza. It's all H1, 80% H1N1 and H3N2, so 80% of the cases are influenza A, small amount influenza B victorious, and the interesting thing is the Yamagata strain appears to have disappeared. So that shows you where once look at Lily. Lily looks like she's been. Are you alive? Lily, you okay? Oh, hi, okay. She looks like she just decided to give up the ghost too. Anyway. So people have asked about how effective is the flu vaccine. We're talking about the SARS-CoV-2 vaccine not being, it's only 70, 80% protective. Well, that's pretty darn good if you look at influenza vaccines. At best are 50 to 60% effective. This year, because it was a good match, it is 54, almost 60% effective. Now, what is effectiveness? You take a control group and you take a vaccinated group and compare symptoms and outcomes. And there is a 54% benefit to being vaccinated. The highest we ever get is 60%. And why is that? A lot of times it's not an exact match. This year it's an exact match, but the vaccines aren't aren't 100% effective because people have various immune responses. It's not sterilized. In other words, you still can get infected in your nose, all those kinds of things. So it's not 100%, but it's very effective this year. RSV is finally coming down. You can see this, the percent positive in laboratory studies, and then the number of detected cases. And then I've talked about TEPI, which is the Texas Epidemic Public Health Institute, which has got 80% of the wastewater coverage in Texas, looking for all kinds of viruses. It's like an agnostic to the virus type, just sequences everything in wastewater. And Houston, according to the TEPI data, is showing a decline in influenza A, RSV A and B. SARS-CoV-2 looks like it peaked in January, and early January it's coming down. One case, or at least one detection of monkeypox virus in Houston, and the rest of the state of Texas looks like it's beginning to come down, RSV, influenza, and SARS. So all very, very positive. Now, one of the problems with people's vaccine reluctance is that they're beginning all over the world, especially in Europe and the U.S., are beginning to question all vaccines. And we've talked about the R number, measles being the most infectious with an R number of 18. In that case, you need 95% or more of the population to be vaccinated to prevent spread. And so if you fall below that 95%, you'll see outbreaks first in measles. So in Europe, there is an alarming increase in measles cases. More than 30,000 people were infected in 2023, compared to 941 in all of 2022. And of those 30,000 people, if you think it's not serious, 21,000 were hospitalized, 5 measles-related deaths, and these are mostly in children. 40% of the cases are in kids age 1 to 4. And that was just because the vaccine rate dropped in Europe from 96%, or we said above that 95% threshold, to 93%. And what that allows, that small percentage, and you look at all the people in Europe, it allows 1.8 million children to be susceptible. And so, when we talk about these changes in the way people view vaccination, that's real-world consequences. These are thousands and thousands of hospitalizations and a few deaths because people aren't getting vaccinated, not only for COVID, but for measles. There was an interesting op-ed in the Washington Post recently saying, what was the biggest, look back, what were one of the biggest failures or policy failures of managing COVID? And one of them was that we didn't prescribe Paxlovid enough. And there's a bunch of data to show that Paxlovid was very effective. Hospitalization rates were 51% lower in those that received prescription Paxlovid versus unvaccinated people. There was an 89% reduction in severe COVID with those who received Paxlovid compared to the unvaccinated, and yet only 28% of the people who were eligible received it. There was a retrospective study looking at 1 million patients, and Paxlovid reduced 28-day hospitalization and mortality by 26 and 73% respectively, and there was another VA study showing that you were 26% less likely to develop long COVID if you're treated with Paxlovid. So Paxlovid came on the market, was really effective, and the problem was a lot of physicians didn't prescribe it. So, that was a failure on our part, the public health system and physicians, to not prescribe Paxlovid when it was eligible. And people who got COVID and took Paxlovid could feel the impact right away. I mean, it's a pretty dramatic, and yet we didn't prescribe it enough. Two interesting studies came out about long COVID, all of which are looking at how can we diagnose it better. There have been a bunch of hypotheses of what causes COVID. One is that there's tissue damage, and that causes inflammation, that viral persistent reservoirs exist, that there's autoimmunity or persistent inflammation. And there were 2 studies that showed, one, that the complement system seems to be activated, so you can detect complement products, part of the inflammatory response. And then there was another study looking at immune dysregulation as evidenced by T-cell dysregulation. So 2 examples where inflammatory system seems to be altered with long COVID. Maybe that'll turn out to be a marker that we can detect, and it's probably not just specific to COVID. It's probably true of all people that get sort of long-term complications of viral illnesses. There was one other interesting question. A person asked, are people getting more or less long COVID with the recent strains? And it is interesting to see that as the strains have become less and less virulent, it also looks like there's been a slightly drop in long COVID. So there was a study that looked from June to 1 year, from 22 to 23, June 1 to June 1 that year, and the prevalence of long COVID decreased from 7.5 to 6%. suggesting, in that long COVID has been dropping pretty significantly. There's another study that had it decrease from 20% to 11%. So it looks like long COVID is getting less and less as the virulence has dropped. I want to end today with a couple of shout-outs, or several shout-outs. The first, congratulations to Peggy Goodell, the chair of the Department of Molecular and Cell Biology. She has been elected to as a fellow of the American Association for Cancer Research. This is really recognizes outstanding research in the field of cancer. She's one of the top scientists here, and so congratulations to Peggy. Also, congratulations to Ben Deneen, a professor of neurosurgery and director of the Center for Cancer Neuroscience, has been awarded the 2024 Edith and Peter O'Donnell Award in Medicine from the Texas Academy of Medicine, Engineering, Science, and Technology, or TAMIS. He's among 5 other scientists and engineers who were recognized for their groundbreaking work, so congratulations, Dr. Deneen. And finally, blood drawing is coming up. There'll be a blood drive on February 5th and 6th in the Razor Lounge. Obviously, we need blood donations for our hospitals. We will also be hosting a voter registration drive January 29th and February 26th. So we want you to both give blood and to vote. So anyway, as you're thinking about giving blood and voting, have a wonderful weekend, and I can't wait to see you next week.